Dr. Suzuki has been a friend for decades. He's been up in the San Marino, Pasadena area. Anybody seen the Dr. Drew series? He's kind of probably embarrassing for him. His unit was at Los Angeles Hospital. It is the kind of now premier psychiatric hospital for Los Angeles. And he's the psychiatric director. He runs that place. And we got him here. He's a believer and very well respected as a teacher as well as a speaker for different audiences. So we're very fortunate in having him to talk about bipolar disorder, and we'll see how he is, and we'll have some time to ask questions later in the morning. But you, Dr. Suzuki, can come on up and we can start.
Good morning.
Wake now.
Good morning. Well, I'm very excited to be here this morning and very excited to see all of you here this morning. To tell you a little bit about myself and my journey here. I fell off the branch of the evolutionary tree. My father was a pastor, I'm a PK, and my grandfather was a pastor also, so I had a double dose of that. I didn't quite go that route. But my family came from Hawaii to Japan, or Japan and Hawaii in the early 1900s, and they came to work on the plantations there. And they were all Buddhists. But with the help of the Salvation Army, a lot of minister groups there, literally on the beaches of Hawaii, they became converted, became Christians. And my father became a pastor, I think was ahead of his time, and despite his culture, he was very sensitive to the emotional and psychological needs of the pastor, the people in the church, in addition directly to their spiritual needs. I think that was a part of the basis of my sensitivity in that area. And when I was in medical school and trying to decide should I become a surgeon or become medicine, part of the reason I chose psychiatry is I thought that during my lifetime there'd be a huge explosion of understanding about brain chemistry and function and how to help the seriously mentally ill. And so I chose to go into psychiatry. Now, I haven't been disappointed. When I was in medical school 35 years ago, we had one medication for bipolar disorder. I'd say we had a dozen different medications. And when I was in residency, we didn't even have Prozac at that time. So there's been this huge explosion in the last 30 years. But the other thing that's been very heartwarming is to see the evolution in the church. There's been a reawakening of the need to understand and serve those with mental illness, both in the church and outside the church. And I say reawakening because, particularly being in your church here, friends, as Dr. Okamoto alluded to, the Quaker Church was at the forefront of mental illness treatment in the United States. 1813, they had the first private psychiatric hospital. And as Dr. Okamoto is saying, it was a real shift from literally mental illness in shame to understanding that God is with those people also. They needed compassion and help. And so again, the fact that you're all here this morning on a Saturday morning is really very heartwarming. And Mike did a great job talking about bipolar illness in the pediatric population. One disclaimer, which isn't on the slide here, is that I'm not as funny as Mike is. I give most of my lectures to other psychiatrists with neurochemistry and neurotransmitters and charts and graphs, so I get to be pretty boring. Because a lot of us in psychiatry are boring people. But I'll do my best here to try to explain some of this here about bipolar disorder. So, there's two important points I want to make sure that you leave here this morning and understanding. The first point is that bipolar disorder is a medical illness, and that's a very serious, progressive neurological disease process, and we need to take it very seriously and help people with this. But the second point, which is equally important, is that bipolar illness does not need to define the person. Right? That's just one part of who that person is. Now, I've treated many people who are great husbands, great wives, great mothers, fathers. I treat other doctors, psychiatrists who have bipolar illness. I treat other people who are missionaries and pastors. So having a bipolar illness is not to define who you are, you can have a wonderful, abundant life even having that particular illness. So just like there are people with diabetes, chronic medical illness, or professional athletes, there are people with bipolar illness that can lead very normal lives. So again, very important. So the first point about this being a serious mental illness, got to hook that up with the fact that there's a lot of treatment that people can live very fulfilling lives despite having that illness. But it is a medical illness. And just like all medical illnesses, there's a diagnosis, there's particular symptoms, there's genetics related to it, and there's treatment. So I wanted to explore those different things this morning. So, it's very hard to see, the slides are small. But like Mike was saying, there are, in order to have the diagnosis of a bipolar illness, you need to have a manic, or what we call a mixed episode. So we often think of bipolar illness, people use the term manic depressive illness, that's sort of the old term. But the reality is you don't need to have a depressive episode in order to have a bipolar disorder. You need to have one episodes. And oftentimes a person may have a manic episode before they've ever had a depressive episode, and that can be confusing diagnostically. We'll go over in a minute more specifics in terms of what that means. I'm sorry, did I break the mic? Okay, is that better? Maybe I'll hold this. So people, though, with bipolar manic depressive illness, they often have, ahead of time, either depressive episodes or mixed episodes, or after they've had a manic episode, they can have subsequent depressive episodes. We'll go over that. And then, thirdly, there is a time course. So, many of us have ups and downs, but it's the amplitude of those ups and downs that counts, and also the longitudinal history. It has to be at least 1 week. So, manic episode. Mike went over a number of these. You see them on the screen: grandiosity, decreased need for sleep, pressured speech, racing thoughts, distractibility, increased activity, excessive pleasurable or risky behavior. But to put this all together in context, think of it as like your brain being on fire. It's going way too fast, and it's just going and going and going. It's like being on caffeine all the time. So if you think of yourself not sleeping, your mind going all the time, these are the types of things that gets to happen to you. Now, things like grandiosity, if I tell somebody, well, I have a personal relationship with the creator of the universe, and I talk to him every day, well, that sounds pretty grandiose to maybe somebody who's not a believer. So what's important is that you have a constellation of these symptoms. It's not just one of them, you have all that mixed together. So for example, and as Mike alludes to, we have to be very careful in terms of confidentiality. So I'll change different demographics of people I talk about. I was treating somebody in the hospital this week, and he's a 50-year-old gentleman. And he tells me that over the last month, God's been speaking to him, and God's told him specifically to go to Las Vegas and do a bunch of gambling. He's going to make a lot of money, and specifically, he's supposed to give $30,000 to the church. Right? Now, if God was speaking to him, the pastor of their church would probably be very unhappy if I told him, gee, you're manic and you shouldn't go to Las Vegas, because the church would be out $30,000. Right? But the reality is, when you talk to this man, he's saying, well, God just told me this for the first time a month ago. Oh, gee, Doc, I'm also not sleeping. I'm sleeping 3 or 4 hours a night. I'm talking to him. He's talking a mile a minute. He's getting up, he's moving around. So he has a whole constellation of these symptoms. It's not just one thing. And that becomes important because at any given time, at our hospital, there may be several people who say, I'm God, or God's speaking to me, or I'm supposed to go save the world. And hard to know at times whether this is a specific symptom of just who they are, it's their theological bent, or if in fact they're having a bipolar manic episode. But if you talk to these persons, you put all those symptoms together, what you find is a picture of being manic. Now, people with bipolar illness often have depressive episodes before or after. As the name implies, we used to call it manic depressive illness. It's a classic picture before we had medications of a bipolar illness, as people would first be manic and then they would crash into depression. And we went over some of the symptoms of those. Impairment. Well, first of all, you have to meet one of two criteria. Right? You have to either feel depressed, or you have to, secondly, have a loss of interest in activities. And depending on what cultural background you come from, so I come from a Japanese culture, traditionally it's not very acceptable to say that you're depressed. That's just sort of a no-no. But oftentimes people say, if asked them, I've lost interest in things I used to enjoy. I don't like going fishing. I don't like to be with my grandkids anymore. So you don't need to necessarily feel depressed or articulate that in order to have a depressive episode. A loss of interest in activities is one of those symptoms. And in addition to that, people have changes in their sleep, their appetite, their energy, their concentration is a big one, feeling worthless, suicidal thoughts. And sometimes there are certain ways that we in psychiatry look at depression where it might be more characteristic of a bipolar depression compared to those people who just have depressions and don't have manias, what we call a unipolar depression. And so in a bipolar depression, again, not everybody with a bipolar illness who's depressed has these characteristics, but traditionally, I tend to think of it and teach it as like a hibernating bear. So people with bipolar depressions tend to want to sleep more versus less. They want to eat more versus less. They're hyperphagic. And they're psychomotor retarded. They're slowed down as opposed to speeding up. And the thing with bipolar illness and depression as opposed to people who are just depressed, it can come on very suddenly. Right? So people with traditional major depressive illness don't get manic, they just have depressions. If you go back historically over the years and look at records, people would take several weeks to get more and more depressed, last for several months, and then they'd sort of come out of it over a period of time. With bipolar depression, these mood shifts are very staccato. One day they can be manic, the next day, boom, they wake up, they want to continue to sleep, they sleep 12, 14 hours a day. It's a very rapid mood shifts. So that's one of the ways we think of bipolar depression being different than just unipolar type of depressions. And same thing, they're very slowed, very psychomotor slowed down. It's a very slowed down type of depression. Now, one thing also that Mike was talking about is mixed states. So mixed states is probably the most dangerous of all bipolar episodes, because on one hand, your mind's racing, you're very agitated, you're filled with energy, right? But at the same time, you're very depressed, just wanting to be suicidal. And so you mix that depression with anxiety and feeling overly active and energetic, that's a mixture that you start being self-destructive. And so that's a very dangerous state to be in. And unfortunately, compared to when I was in medical school 35 years ago, we have the illness has really morphed. Right? It's different than when I saw it 35 years ago. And the question is, well, why is it different? Right? Obviously, the human body hasn't changed in 35 years. Genetics hasn't changed in 35 years. But the unfortunate reality is we have iatrogenically caused complications. Right? So iatrogenic is something that we doctors do, or medications that we give to try to help people that's making things worse in some way. Right? Like if you have pneumonia, you're given antibiotics, you have diarrhea. Or you get chemotherapy, it can affect your bone marrow. We, unfortunately, in psychiatry have done a lot of disservice to people in this country by doing the wrong things, partly out of ignorance. So probably the two of the things that has changed since I was back in med school 30 years ago is the use of antidepressants. Right? So 30 years ago, Prozac didn't come out until 1987. Once Prozac came out, everybody started getting antidepressants like water. Right? It was safe, it was relatively effective, you couldn't kill yourself with an overdose. So we have multi-millions of people taking antidepressant medications. And the unfortunate reality is that probably people who don't need antidepressants are getting them. Right? But people who need antidepressants still aren't getting them. So oftentimes the wrong people are getting the medication. You have somebody with a bipolar disorder, you give them an antidepressant medication, they can pharmacologically switch from being in a depressed state to a full-blown manic state. Right? So see Mrs. Smith comes in the door, gee, Mrs. Smith, you're sleeping too much, you're not eating, you're sedated, you've lost interest in activity. I'm going to give you an antidepressant. And all of a sudden, 2 weeks later, she comes back and, gee, I'm the best I've ever felt in my whole life. I don't sleep, I'm socializing, I'm the life of the party. We flip them into depression, into mania. And we've caused a person to flip into a mania, and that might be more treatment resistant, and they're cycling. They're both depressed and they're manic. So that's one problem, something to be very cautious about. So when I teach medical students, I make sure to give them the antidepressant medication, ask all the screening questions first to make sure that they may not have a manic predisposition. The second thing, and Mike knows this more than I, we are using a tremendous amount of ADD medications, particularly in our kids. And definitely we need ADD medications. Many children, it's very critical in order for their character development, personality development, to get that under control. But you have somebody who is on a stimulant and has a bipolar predisposition, you can again flip them into mania and cause them to rapid cycle. So in years past, you'd see somebody who was just depressed in the bipolar state. You'd see somebody who is in a happy, just effervescent, happy manic state. But in this day and age, particularly in the hospital, you see a lot of people in these mixed bipolar states. They're not sleeping, they're too energetic, they're talking all the minute, but they're very dysphoric, very depressed, they're very sad, they're very agitated, mixed states. So giving people antidepressants, giving people stimulants for ADD certainly are important things to do, but you need to very carefully pick and choose those people because you make the bipolar illness a lot worse. The other thing that's not exactly iatrogenic, but is a bit of a problem, is actual drug use, right? Using people or using drugs on the street, substance abuse. And again, that can stimulate bipolar illness, and again, can make it a more treatment refractory course. So we'll talk about comorbidity in a few minutes. So bipolar, the genetics and prevalence. So depending on who you read, the bipolar disorder in the United States population is about 2.6%, right? If you use the same criteria, be it in Japan or Africa or Europe, use the same criteria, the prevalence rate is about the same. So again, bipolar disorder, just like certain types of cancer or say asthma, I mean, it's cross-cultural. It's not something that we have just here in the United States, it's throughout the world. And if you use the same criteria, and it's very important to do that, we use the Diagnostic Statistical Manual, you can categorize people having a bipolar illness, which should be the same as here or in New York or in Africa. That way, we can do research that specifically tries to treat that specific disorder. Now, if you translate that to the church population, if you translate it to the United States, if there's about 350 million people in the US these days, there's probably over 8 million people with some type of bipolar disorder. 8 million people, that's a huge amount of people. If you translate that to a church, if you have a church of 500 members, that means probably about 12 people in your church have a bipolar illness. If you have a church of 1,000 people, about 25 people in your church will have a bipolar illness. Now this has no social economic boundaries, this has no church boundaries, it has no really male-female boundaries, it's very prevalent. So again, the church are often the first responders to people who are having manic episodes, depressive episodes. So that's why I think this is so important in terms of recognize what and how we might serve people with this particular illness. So very, very prevalent illness. Second thing, if you look at the genetics of it, like most major psychiatric illnesses, major depression, other bipolar disorder, schizophrenia, there's a genetic predisposition. It doesn't come out of the blue. So like most other medical illnesses, you probably have some genetic loading, some predisposition for it, and it's more or less likely to come out based on the genetic loading and also the environmental factors. So an analogy I like to think of is cardiovascular disease. If you're predisposed to have high cholesterol, you can be the healthiest Southern California, eat nuts and vegetables, exercise all the time, go to the gym, and still have high cholesterol. I mean, you're just genetically, that's who you are. But there are other people who are a little genetically loaded, and depending on your exercise pattern, your lifestyle, you may have high cholesterol, you may not. Same thing with things like bipolar disorder, schizophrenia, panic disorder. People are likely predisposed for it, and depending on how genetically loaded you are, how you live your lifestyle, your associations with friends, your psychological state, your traumas as a child, it may or may not come out. So that's why these illnesses, it's not just medication treatment, but it's how the therapy we'll talk about is important in how you live your life. One of the earliest genetic studies done on bipolar disorder comes out of Pennsylvania, the Amish. Right? The Amish people, because of religious persecution and other factors, were very sort of genetically isolated groups of people, and they have less substance abuse, so it's easier to pick up. Do you have any Amish people here? My understanding, the Amish people are relatively calm people that have sort of a certain lifestyle. So if you become manic when you're Amish, it's much more apparent than if you live in Southern California where everybody sort of sex goes around the world. Right? So the Amish were very good populations to study, both in order to identify symptomatology as well as to have sort of a pure genetic pool. And so back in 1976, almost 35, 40 years ago, they started doing genetic studies on Amish, and they're still doing those studies and following those people. And if you pull all the genetic studies together, in general what you see is people who have a first-degree relative, if mom or dad has a bipolar disorder, depending on your studies, maybe have about 10 to 15% likelihood of developing bipolar disorder. What's interesting, if you look at identical twins who have the same genetic makeup, if this is a purely simple genetically transmitted disease, like you could look at the eye coloring and things, if it was that simplistic, then every identical twin, if one has bipolar disorder, the other should also. Right? But in reality, what you see in the studies is between 40 and 70%. So again, the genetics of most of our psychiatric illnesses are incredibly complex, involving a lot of different abnormalities that come together and fit patterns. And so even identical twins, even as one has bipolar disorder, doesn't mean the other one is going to. Again, there are probably environmental factors that come into play that determines whether it comes out or doesn't. So again, that's where it's very important in terms of how we treat and deal with kids as they grow up developmentally, and how we deal with things as adults. So how about treatment? So again, remember the second thing I said, which is probably more important than the first thing I said. The first important thing is this is a progressive neurological disease process. It's prone to get worse if we don't get it under control. But secondly, there are plenty of people with bipolar disorder who have that illness who are doctors and lawyers and great mothers and great fathers. But it's very critical to identify these people early, get it under control so they don't have repeat episodes. Again, if you go back to history, historical data on people with bipolar illness before we ever had any medications, what you find is that the more episodes you have, what happens is the cycle frequency, the time in between episodes gets shorter and shorter, and there's an increased intensity. So again, it's a progressive, just like diabetes, a progressive neurological disease process where if you don't treat it, it's going to have long-term complications. So part of treatment, I think, number one, just like in real estate, it's like location, location, location. Yeah? With most of our illnesses, it's about education, education, education. Got to educate the person and re-educate the person, and keep educating the person. You have to educate the family, right? I think this is a terribly destructive disease for families, as well as the community, churches, people who can help assist in helping these people. So in terms of education, what I like to tell people, this is very much like diabetes. Right? So diabetes is an illness which, again, people can be professional ball players and still be diabetic. What's important is they understand the illness. Like diabetes, with diabetes, the more your blood sugar's out of control over time, you start having microvascular disease. That's why people go blind. Their kidneys go bad, they're on dialysis, they have heart disease. Same thing with the bipolar disorder, cycle frequency will get less, they'll have more intense episodes, they'll become more treatment refractory. So they need to understand that this is an illness you need to respect. Right? As we said before, it's not just the biology of this, but it's all the environmental factors, both externally, you lose your job, you get divorced, you go bankrupt, as well as internal issues. Do I have a fight with my spouse? I have to deal with issues of trauma growing up. All these factors are going to play a part
in the development of the illness, just like with diabetes. Right? If you don't eat right, if you don't exercise, those are equally important to stay healthy. And like if you're diabetic, as you know, you've been taught the warning signs if your blood sugar is too high, right? And you like give yourself a little more insulin. If it's too low, you get some sugar in there. Same thing, if you have symptoms that you can see, gee, the last week I'm sleeping 7 hours, 6 hours, gee, I'm sleeping 5 hours, usually I sleep 8, I'm going to be getting hypomanic. I better try to get some sleep, I better call my doctor, I better maybe adjust my medication. So just like your blood sugar going up and down, there's warning signs, there's equal warning signs in terms of if you're bipolar, that your mood's destabilizing. Right? And one of the things that is a repeated therapeutic issue, I think, with a lot of patients, once they know they have bipolar illness is, boy, and I saw a patient last week, I'm really happy this week. I got to see my kids, I went skiing with them, but I'm worried, is this part of getting hypomanic, am I getting manic, or am I just having a good time with my kids? But that's one of those common issues that gets talked about they need to deal with in therapy, so that people have a sense of what's normal up and down, what is symptomatic, gee, I better increase my lithium dosage. It's all about education, education, education. And equally important in terms of educating family. If you have a spouse or a child with bipolar disorder, the other sort of therapeutic issue gets to be, I get tired of my wife telling me, gee, I better take my lithium because I'm getting manicky. So what's the normal range? So the family needs to be educated so that they want to be part of the solution or the warning signs to watch for, but they don't feel like people don't feel like they're being held upon. So education, critical factor. Psychotherapy, again, there's psychoeducation, there's family therapy, there's therapy to deal with how to deal with external stressors, how to deal with underlying psychological issues you need to resolve. And then there's the medication issue. And again, back when I was in school, lithium was the one and only bipolar medication 35 years ago. Today we have a dozen different medications. So on the one hand, there's all these different options, but that's why it is important to see a doc who can deal with the medication. Again, the doc needs to be able to help the patient understand how to use the medication properly. Because again, the patient they're the ones who know most about how they feel and what's going on. So it's important that the person be educated. Real quickly, as Mike was saying, and we were talking about earlier, the danger is if you have a bipolar illness, the first rule of thumb, is you really want to avoid as much as you can antidepressant medications. Okay? So if you're a purist in the ivory towers of UCLA Psych, do not ever give a person with a bipolar illness antidepressant medication, because that may get them out of their bipolar depression, but in the long run, you're going to destabilize the person. They're in a rapid cycle. Right? Now, there's different, it probably shouldn't be that purist. There are people, and there are studies that indicate some people with bipolar 1 disorder, maybe some with bipolar 2 disorder, they do need antidepressant medications because they'll help keep them out of not only downs but the ups. But in general, the rule to think about is if you're being given an antidepressant medication, even if you have not been yet diagnosed with a bipolar disorder, it could flip into mania, so you have to watch for that. But if you know somebody that's a bipolar disorder, then you want to, as much as possible, avoid antidepressants. What we do is load people up with mood stabilizers. Right? So antidepressants bring you up, mood stabilizers bring you towards the center. If you're depressed, they'll bring you up. If you're up, it brings you down. So it brings you into a normal bandwidth here. Right? And there are 3 traditional mood stabilizing medications that we use frequently. One is lithium, other is Depakote, valproic acid, and the third one is Lamictal, lamotrigine. Now, lithium has a very interesting history. So if you go back, so lithium is the only psychiatric medication I think we use regularly, which is a commonly occurring element in the earth. Right? If you go back to the chemistry tables of elements, lithium is on there. Right? So you can't get any more natural than lithium. Lithium is mined from the earth, and it's purified and synthesized in the compounds we use, but it's an element. So lithium traditionally has been one of the medications that was first approved for bipolar disorder. If you go back hundreds of years, and you go back to Europe and a lot of those mineral healing baths, if you go there and measure the water, they have very high lithium content. And it's interesting, I was looking back, I saw this article on Harper's Bazaar magazine, which is like a 100-year-old magazine, this commercial, and on the advertising it was selling lithium buffalo water. They were selling gallons of this type of water that had lithium infused in it. So we've sort of understood for many years that lithium has some type of healing power. And lithium traditionally has been used quite a bit, but lithium also has a lot of side effects. The therapeutic index, which is how much it helps you versus causes you side effect problems, is very narrow. So we get blood levels of lithium all the time. But I also like to use this as an example for my patients. A lot of my patients come and say, well, gee, I'm taking this supplement or that supplement. Is it safe? Is it unsafe? And I'd rather take natural things rather than taking a drug that you're giving me. But the reality, again, is lithium is as natural as you can get it, but it's one of the most dangerous medications you can give people. Right? It can cause birth defects in kids. It can cause kidney toxicity. It can kill people if you take too much lithium. Right? So it's a naturally occurring element, but it's still very dangerous. Again, nothing wrong with natural remedies out there, but again, just because it's natural doesn't mean that it's safe. Depakote valproic acid is another mood stabilizer. Those two medications are probably the ones that we use most traditionally as regular mood stabilizing medications that can be very effective if used properly, but they all have side effects. And again, bipolar illness is a very dangerous progressive neurological disease process, so you need very serious medication which can have side effects. So you have to discuss with the doctors the pros and the cons. But a lot of them, if you can get by with it, people try to minimize that. Lamictal, lamotrigine, is something that I think the public is getting to hear more about, a very common mood stabilizer. It doesn't cause weight gain, doesn't cause cognitive problems. It's not real good at protecting the mania, but it's better for protecting the depression and hypomania. So sort of less severe bipolar type 2 cases use a lot of Lamictal, lamotrigine, so that's another alternative. Now, other than those three main mood stabilizers, there's a class of antipsychotic medications. So another problem we have in psychiatry is we have done a poor job in terms of medication classification. So whenever I give a person medication, what's the first thing they do? They go home, they look it up on the internet, right? And so there's a whole class of medications called atypical antipsychotics. And they're antipsychotics because we use them for psychosis and schizophrenia. However, they're also mood stabilizers, right? And so even though I'm giving it, I'm very clear, I'm giving this to you because you have a bipolar illness. This will help keep your moods in control. And you're going to look it up and you're going to see it's an antipsychotic. I don't think you're psychotic, but it's a mood stabilizer. So there's a whole bunch of people working, I'll take probably another decade, of reclassifying their medications so they're not just antidepressants or antipsychotics, but they'll be based on their classification. Right? This is an NMDA receptor medication. This is a receptor. This is a medication that hits serotonin receptors or something to that effect. Because right now, again, going along with the stigma, how many people want to go to the pharmacist and give them a prescription for an antipsychotic medication? Or if somebody goes into your house and opens your cabinet and you see a prescription for Zyprexa, which people think it's an antipsychotic, it's also FDA approved as a bipolar medication, as a mood stabilizer. So again, there's all the stigma, and part of the problem with medications are nomenclature on that. Now also, as Mike was saying though, a lot of people don't want to take their medication. A woman in the hospital, currently she's very manic, she's doing much, much better, but she likes being manic. So I'm having a hard time convincing them to leave the hospital. You really need to keep taking this medication. That's very difficult. So again, it's all about education, helping people understand this is a progressive neurological disease process. The reason you don't have another episode is because this could get worse, and it's up to you. These are the side effects. These are what the medications help you with, but you decide. But it's all about education. But people get manic. They are happy. They're energetic. They don't want to control that. And so often they stop taking their medication. And taking vitamin pills, I don't take my vitamin pills every day. How many people take their medications every day, and these are medications that they, back of their mind, may not want to take. So there is one, so in schizophrenia, a big shift we're moving towards today, which is very important, is giving people long-acting injectable medications. So there's some schizophrenic medication now which you can give a person an injection once a month, every 2 months, every 3 months. That way they don't have to remember taking the pills every single day. And the same thing goes for bipolar medication. Now, most of these medications you have to take it every single day, but there is one medication now which has been FDA approved as an injection, and they get an injection once a month. Right? A lot of people, gee, I don't want to get an injection, but you know, if you had a serious medical illness, you'd be injecting yourself once a month. You know, if you had a diabetic, you give yourself insulin every day. These are serious illnesses that need serious treatment. So something to think about. And again, that's where education is so important. Not only the doctor with the patient, but good for patients to talk to their family members, because often it's the family member that will say, gee, Johnny, you know, you've been doing pretty good, why do you need to keep taking medication? Right? So the more the family understands, and groups like NAMI, it's incredibly important to help educate the family so they become a part of that whole process. So, you know, part of bipolar illness, if it gets to the extreme, one of those extremes is psychosis. People can have auditory hallucinations, people can be delusional. And I'm going to catch that plane and go to South America because I believe that I'm going to become a king of Ecuador. Right? So people do all kinds of crazy things which are extraordinarily dangerous to them and people around them. And so there are times when people get to the point where they need psychiatric hospitalization. So you know, either people, ideally, you talk to the family members, you talk to the patient, they voluntarily agree to go in the hospital. But there are times when they're doing things so dangerous, either endangering other people, they get very depressed, plus very agitated, they're going to hurt themselves, or so they're so gravely disabled. Now, if somebody, you know, not uncommonly, people go out and buy a brand new car, drain their bank account, you know, and then after the fact, it's, gee, doc, can you write a letter to the judge or to the car company saying, gee, I was manic, and I spent this money in the car, and it was because I was not in my right state of mind. That doesn't count legally. So people can destroy their lives, they have a lot of collateral damage. So it gets to the point where they're self-destructive in all these different ways. Hospitalization is one way to do it. If people don't voluntarily want to come to the hospital, there are specific criteria. If they're in imminent danger of hurting themselves, hurting others, or gravely disabled, and unable to provide food and shelter for themselves, they can't be involuntarily put in the hospital. So hospitalization is sort of the one extreme you can do. There's partial hospitalization, that where the patient comes to the hospital 5 days a week from like noon to 1 or 2, keep under close monitoring, have some good therapy, medication monitored. And then there's IOP, which is outpatient, where they come maybe 3 days a week for just the morning time. So there's the different gradations of care that they can be given. Now this would probably be a whole subject for another hour or two, but I did want to make sure I put this in for a short period of time. Substance abuse, which is another medical illness, is a huge problem in terms of a lot of our psychiatric illnesses, particularly bipolar illness. So I would say the majority of people who come into my hospital with bipolar disorder, just like statistically, they 60% have a comorbid substance abuse problem. I always say it's more than 60% of hospital patients. So those are people who have a true alcohol illness, you know, they're using opiates, heroin, cocaine, meth, you name it, plus they have a bipolar disorder. Right? And you have a lot of great chemical dependency residential treatment programs. Unfortunately, they don't always treat the psychiatric comorbidity. Comorbidities, you have two different things. And many people get good psychiatric care, we don't have to pay attention to, gee, I drink 8 beers at night time. Right? But if you don't treat both of them simultaneously and both equally aggressively, if you just treat one, the other will cause it to flare up. It's just a revolving door. Right? So you get the mood under control, but people are continuing to drink. Alcoholism, depressant will make your brain depressed and it goes round and round. And when you're manic and disinhibited, you want to drink or do something to feel better. And if you're depressed, you want to alter your states or using drugs. And it goes round and round and round and round. So comorbidity, again, is a very common occurrence. And again, it's probably open to another workshop at some time in the future, but I would perceive it also as a medical illness. People are genetically predisposed to alcoholism or many of these drug problems, and it needs to be treated in a way that is understandable of different factors. So to summarize here, again, those 2 points I told you, And again, I think I said it multiple times, bipolar disorder is a progressive neurological disease process. It's a chronic illness. It will likely get worse if it doesn't get better. And so it needs to be caught at a very early stage and treated very aggressively. So at my hospital, one of the things I focus on that we specialize in is college-age kids. We may at any given time have 10 different college students in our hospital setting. Age of onset, they begin to have things like bipolar disorder, tons of substance abuse in college, and the psychosocial pressures, academics and social life in college all come right to the surface. And the reason I love to work with college students in the hospital is that's the point in time where we can change the trajectory of the illness. If you don't attack it aggressively, they could be doomed to a horrible life of substance abuse and repeated episodes and never get through college and be terrible. Or if you can educate them, educate their family, get them on the right medication, get them at the therapist and educate them, you can literally change the trajectory of that illness. You can change the course. And so the second point being, this is a very, I wouldn't say very treatable, it's a very serious illness and there's different degrees, but an illness that certainly can be treated and treated appropriately. And again, there are plenty of pastors and missionaries and doctors out there and moms and dads who have this illness. They still lead wonderful, abundant, full lives. They need to respect it just like if you have diabetes and you respect that illness. So remember those 2 points. Don't forget that, don't remember the first point if you don't get the second point. And this is a very treatable illness. We need to do everything we can. You're coming here today to get a better understanding of this illness so you can help to administer and serve those people with this illness. I think is incredibly great that you all did that. So thank you.